My colleague Brian Smith talked about pharmacological treatments, so the newest drug therapies, and I talked about the non-pharmacological treatments. So he was mainly talking about four newest drugs. You know, everyone knows there are a lot of drugs for epilepsy out there right now. None of them are perfect. Unfortunately, we don't have a single drug that works for everybody, but epilepsy is a very diverse condition. So when we're dealing with patients with epilepsy, we need lots of different options. The newest ones have pluses and minuses, and that's mainly what he was talking about. The first, not necessarily in this order, but he talked about clobazam, which is an interesting drug. It's actually been out in the rest of the world for quite a while, for many years. Only got approved in the US about a year and a half ago, and that was with an orphan status for Lennox-Gastaut syndrome. Interesting drug in that it's a benzodiazepine. We all are familiar with using benzodiazepines for acute treatment of seizure, but in this case, it doesn't seem to cause the tolerance that the other drugs do, so it's used for chronic treatment of epilepsy. And as I said, it was FDA approved for Lennox-Gastaut syndrome, where efficacy was proved, but in the rest of the world it's used a lot for partial seizures, so we are seeing some off-label use of that drug. Advantages are it's a really long-lasting drug, long half-life. As a benzodiazepine, it's got some anxiolytic properties which are sometimes helpful. Downside, if it's there, is probably sedation. So this is, you know, an option that is not going to replace anything out there, but is being used for epilepsy. Another one relatively new in this country is eslicarbazepine, related to two previously approved drugs, carbamazepine and oxcarbazepine. Slightly different structure. We don't know yet whether that's going to be a clear advantage or not, but the indications are there might be some advantages of this drug. Like clobazam, it's been out in the rest of the world for a little bit, actually a couple of years, so the Europeans have more experience with it. Advantages are long half-life, can be dosed once a day. Some people find that helpful. Hopefully it's at least as effective as its cousins, and because of the metabolism it may have fewer side effects. That's something that we're gaining more experience with, and so far it looks like it may be a useful option. Also has less in the way of drug-drug interactions than the other two, which can be helpful in some patients. Another recently approved drug is perampanel. This is a drug for epilepsy with a different mechanism, also approved for partial seizures that are refractory. That's the initial approval for pretty much all drugs because of the way they're tested in the US. The different mechanism is it's actually an AMPA antagonist. There's no other drug that has that mechanism. Now, does that mean it's more effective? No. But conceptually, we might like to use a drug with a different mechanism rather than a mechanism that somebody's already failed. Main disadvantages come out with this drug is psychiatric side effects. There's actually a warning from the FDA about suicidal and homicidal ideation. So we don't know how common that's going to be, but it is concerning, and we're going to be using that drug with caution. The last one is probably not going to be used much. That's ezogabine, basically because of the side effect profile. It was a recently released drug. There were some concerns even when it was released, and then subsequently it was found to cause bluish discoloration. So people would get like dusky lips and bluish hands, and it also, and that's not a great thing to happen, but also it may do the same thing in the retina, and there's worry about retinal problems. So, people who try this, it's going to be with great caution, and it's going to be with frequent ophthalmological exams.